You can feel completely fine. No chest pain, no shortness of breath. You go in for your yearly checkup, your basic blood work comes back normal, and your doctor says everything looks good. And yet, underneath that normal-looking report, there can be information about your cardiovascular risk that a standard panel simply wasn't designed to catch.
This isn't about panic. It's not about telling you that your doctor missed something or that your arteries are secretly falling apart. It's about something much simpler and much more useful. There are 5 blood markers that, when understood correctly, can give you a clearer picture of your cardiovascular risk after age 40. And some of them require a specific conversation with your healthcare provider because they aren't automatically part of a routine panel. In this video, we're going to walk through what these 5 markers are, what they can and can't tell you, and how they fit together. By the end, you'll have a much better sense of which questions are worth asking at your next appointment. Somewhere around your 40s, cardiovascular risk tends to shift. Metabolism changes, blood vessels lose some of their elasticity over time, hormonal shifts, particularly around perimenopause and menopause for women, can influence cholesterol patterns. Years of lifestyle habits, some healthy, some not, start to show their cumulative effects. None of this means cardiovascular disease is inevitable. It means this is generally a reasonable stage of life to take a closer look at the numbers that matter, rather than waiting for a symptom to show up first. Cardiovascular disease remains one of the leading causes of death in the United States, and one of the more frustrating features of it is that early changes in blood vessels often don't come with obvious symptoms. That's exactly why the numbers on a lab report can be so valuable, not to frighten you, but to give you information while there's still plenty of time to act on it. Before we get into the 5 markers, there's an important clarification to make, because the title of this video could easily be misread. Some of the markers we're about to discuss are commonly included in routine blood work, like a standard lipid panel or metabolic panel. Others require a specific test to be ordered, sometimes because they're considered advanced or specialized testing, and sometimes simply because they're not part of the default panel your insurance or clinic typically orders. That distinction matters. A normal basic panel does not automatically mean that every possible cardiovascular risk marker has been checked. It means the markers that were tested came back within expected ranges. If you want the fuller picture, it often takes an actual conversation with your doctor about which of these markers make sense for you specifically, based on your history, your family history, and your overall risk profile. With that out of the way, let's get into the first marker. And it's one that's frequently misunderstood even by people who are already fairly familiar with cholesterol testing. The first marker is ApoB, short for apolipoprotein B. Here's where a lot of confusion tends to happen, so let's slow down for a moment. Standard cholesterol testing usually reports LDL cholesterol, often referred to as bad cholesterol. LDL cholesterol tells you roughly how much cholesterol is being carried by a certain class of particles in your blood. ApoB is a different measurement. It provides information about the number of potentially atherogenic particles circulating in your bloodstream, meaning the particles that are capable of contributing to plaque buildup in artery walls over time. Here's the simple version. Nearly every one of these atherogenic particles carries exactly one ApoB molecule on its surface. So measuring ApoB gives you a fairly direct estimate of how many of these particles you actually have circulating, regardless of how much cholesterol each particle happens to be carrying. 2 people can have similar LDL cholesterol numbers, but a different number of these particles. And that particle count is what ApoB is estimating. You may also hear about LDL particle size, sometimes described as small dense LDL versus large buoyant LDL. This is a related but separate piece of advanced lipid testing, and it shouldn't be confused with ApoB. Particle size is one characteristic of these particles. ApoB is an estimate of how many particles there are in total. It isn't accurate to say that large particles are automatically harmless,
and it isn't accurate to say that small particle size alone determines your cardiovascular risk.
Both particle number and other characteristics can factor into the overall clinical picture. And this is genuinely an evolving area of research. For many people, especially those with borderline or unclear LDL cholesterol results, a family history of early heart disease, diabetes, or metabolic syndrome, ApoB can add useful context. It's not part of every standard lipid panel. So if you're curious about your own number, it's worth asking whether it makes sense to add it to your next round of labs.
The next marker is different because it's largely influenced by genetics, and that changes how we should think about it entirely. LPA, pronounced Lp(a), is a specific type of lipoprotein particle. Unlike LDL cholesterol, which can shift meaningfully with diet, exercise, weight changes, or medication, LPA levels are largely determined by your genes. That means for most people, lifestyle changes generally have limited effects on the LPA number itself, even with significant improvements in diet and exercise habits. Elevated LPA may be associated with increased cardiovascular risk, including a potentially higher likelihood of certain vascular events over the course of a lifetime. That said, having an elevated level does not mean a cardiovascular event is inevitable. It's one piece of a much larger picture that includes your other lipid markers, your blood pressure, your family history, and your overall lifestyle. Because it's largely genetic, many medical organizations suggest that it's reasonable to check LPA at least once in a person's lifetime, and this becomes a particularly worthwhile conversation if you have a family history of premature cardiovascular disease, meaning heart attacks or strokes in close relatives at a relatively young age. This isn't a test that automatically applies to everyone in the same way, and it's not something that needs to be repeated frequently once you know your baseline, since the number tends to stay fairly stable throughout life. If it hasn't come up in a conversation with your doctor before, it may be worth asking whether checking it makes sense for your particular situation. The third marker takes us in a different direction entirely, away from cholesterol and toward inflammation. High-sensitivity C-reactive protein, or hs-CRP, is a marker your body produces in response to inflammation. But here's an important distinction. hs-CRP is nonspecific. That means it doesn't tell you where the inflammation is coming from. A recent cold or infection can raise it. An injury can raise it. Even a hard workout the day before your blood draw may affect the result. Other inflammatory conditions, from arthritis to dental issues, can raise it too. Because of that, a single elevated hs-CRP reading doesn't prove that there's inflammation happening inside your coronary arteries specifically. It's simply information that inflammation is present somewhere in the body at the time of the test. This is where many people misunderstand the result. They assume a high number automatically points to their heart, when in reality, it could be explained by something as ordinary as a minor illness the week before. What tends to matter more is a pattern over time, checked when you're not acutely sick or recovering from an injury. Persistent elevation, especially alongside other risk factors, may deserve further discussion depending on the overall clinical picture. On its own, one elevated hs-CRP result is rarely, if ever, something to lose sleep over. So far, we've covered 3 markers that mostly relate to what's circulating in your bloodstream and how your body is responding to it: particle number, a genetic risk factor, and a general inflammation signal. The next 2 markers shift the focus toward how your body is handling blood sugar, which connects to cardiovascular health in ways that surprise a lot of people. Metabolic health and heart health are far more intertwined than most routine checkups make obvious, and this next section is where that connection becomes clearer.
The fourth marker is hemoglobin A1C, often just called A1C. A1C estimates your average blood glucose over approximately the previous 2 to 3 months. It does this by measuring the percentage of hemoglobin in your red blood cells that has glucose attached to it. Because red blood cells last for a few months, A1C gives a longer-term snapshot rather than a single moment reading.
This is different from fasting glucose, which we'll get to next. And it's also different from insulin resistance, which is a separate underlying process. A1C, fasting glucose, and insulin resistance are related, but they are not the same thing. And it's worth keeping them distinct in your mind.
Here's something that surprises a lot of people: insulin resistance, a state where your body's cells respond less efficiently to insulin, can begin developing before it shows up clearly in routine glucose numbers. This doesn't mean a single normal fasting glucose result rules out insulin resistance. And it doesn't mean one slightly elevated number automatically means diabetes is coming. What it does mean is that trends over time, rather than one isolated result, tend to provide more useful information. If your A1C or fasting glucose has been slowly climbing over several years, even while staying technically within a normal range, that trend itself can be worth a conversation with your doctor. The final piece helps show why looking at trends can be more useful than looking at one isolated number, and it involves two related but separate pieces of information: fasting glucose trends and the relationship between your triglycerides and your HDL cholesterol. We've already touched on fasting glucose. The key idea to hold on to is that a single fasting glucose reading is a snapshot, while a series of readings over consecutive checkups can reveal a trajectory. A number that's crept upward year after year, even while remaining under the official cutoff for prediabetes, may be worth discussing with your doctor rather than dismissing simply because it's technically in range. Separately, triglycerides and HDL cholesterol are two more values commonly included in a standard lipid panel. Some people look at the ratio between the two, triglycerides divided by HDL, as a rough additional data point. It's important to be clear about what this ratio is and isn't. It is not a definitive diagnostic test. It is not a universally accepted standalone measure of cardiovascular risk, and it does not by itself diagnose insulin resistance. What it can do is provide additional metabolic context, particularly when interpreted alongside other information such as blood glucose, A1C, waist circumference, blood pressure, body composition, family history, and your other lipid markers. Think of it as one more piece of context to bring into a broader conversation, not a standalone verdict on your metabolic health. Put together, these two pieces, glucose trends and triglyceride/HDL context, help build a picture of how your body is managing energy and blood sugar over time, which ties directly back into cardiovascular risk in ways that a single snapshot test often misses. To make this a little more concrete, let's walk through a hypothetical example. This isn't a real patient. It's a composite scenario meant to illustrate how these markers can interact. Imagine someone in their mid-40s who exercises a few times a week, isn't overweight, and has never had a concerning result on a standard cholesterol panel. Their LDL cholesterol has always looked fine, but suppose this person also has a father who had a heart attack at 52. If they never ask about LPA, they may never learn that they carry a genetically elevated level, something diet and exercise alone wouldn't have changed, and something a standard panel wouldn't have flagged because it isn't typically included. Now imagine that same hypothetical person also has an ApoB that turns out to be higher than their LDL cholesterol alone would suggest, meaning more atherogenic particles are circulating than the basic panel implied. Individually, neither piece would necessarily be alarming. Together, alongside a family history of early heart disease, they might prompt a more detailed conversation with a cardiologist about a personalized prevention plan. That's the value of looking at multiple pieces of information together rather than relying on a single number to tell the whole story. Let's clear up two myths that tend to circulate around this topic. Myth 1. If my basic cholesterol panel is normal, my cardiovascular risk is essentially zero. As we've discussed, a standard panel doesn't include several markers that can meaningfully add to the picture, like LPA or ApoB. You can feel completely fine and have a normal-looking basic panel while other relevant information simply hasn't been checked yet. That's not a reason for alarm. It's a reason to ask informed questions. Myth 2. One abnormal result means I definitely have heart disease or diabetes. This isn't how any of these markers work. Every one of them should be interpreted in context, alongside your symptoms, your other lab values, your blood pressure, your family history, and your overall health picture. A single number rarely diagnoses anything on its own. It's a piece of a larger puzzle that a healthcare professional is trained to put together.
If any of this resonated with you, here are some practical questions you might bring to your next appointment. You can ask whether, based on your history and family history, it would make sense to check your ApoB. You could ask whether you've ever had your LPA checked, and given your family history, whether that's something worth doing once. You could ask whether your hs-CRP has ever been tested, and if it's ever elevated, whether it should be rechecked when you're not sick or recovering from a workout. You could ask to look at your glucose and A1C trends over the past several years, rather than just this year's numbers. And you could ask whether, given your triglycerides and HDL, along with your other risk factors, there's anything else worth exploring. These aren't demands, they're starting points for a more complete conversation with someone who knows your full medical history. While this video is about lab markers rather than acute symptoms, it's worth a brief reminder. Chest pain or pressure, shortness of breath, pain radiating to the arm, jaw, or back, sudden dizziness or cold sweats should never wait for a scheduled appointment. Those symptoms call for immediate medical attention, regardless of what any recent lab result showed. Here's the message to take away from all of this. The goal isn't to fear every number on a lab report. Plenty of people feel completely healthy while risk factors are quietly developing in the background. And that's exactly why understanding these markers matters. Not so you can panic over a spreadsheet of numbers, but so you know which results may deserve a closer look. The goal is to understand which numbers are worth discussing with your healthcare professional, and to bring that understanding into the conversation with you. None of these markers diagnose anything by themselves. None of them guarantee a future event, good or bad. What they can do, together with your full medical history, is help you and your doctor build a clearer, more personalized picture of your cardiovascular health. This video is educational, and it isn't a substitute for individual medical evaluation. What any of these numbers actually mean for you depends on your age, your family history, your blood pressure, your symptoms, your medications, your existing conditions, your lifestyle, your previous results, and your overall cardiovascular risk. All things only you and your doctor can put together properly. Of these 5 markers, ApoB, LPA, hs-CRP, A1C, and glucose/triglyceride trends, which one was new to you? Let me know in the comments. And if this helped clear things up, consider subscribing for more videos like this one.